Brilliant. We've got a lot to do, so I did want to start on time. So the first thing I want to do is introduce myself. I'm Dr. Linda Harris. I'm a GP by background. I have the privilege of leading an organisation called Spectrum Community Health CIC, a social enterprise that delivers to a range of vulnerable groups, including a number of prison healthcare services, integrated healthcare services in the north of England. I'm also old now, in that I reached a significant milestone birthday a couple of weeks ago, and it reminded me of how many years that I have been affiliated and interested in the world of substance misuse and recovery. So it's absolutely a pleasure for me to bring a number of thought leaders and yourselves as thought leaders collectively with us in the room today to talk about a concept that I hope after today's conversation builds some momentum, builds into a community of practice, a coalition of the willing, if we might call it. And thank you, Sandra. I might feel it's ages just a number, a coalition of the willing in relation to creating a real level of innovation in minimum quality standards in recovery, in healthcare, in prisons. It's a concept at the moment, and what I'm trying to do is test it out, supported ably by some amazing speakers that have really given up their time today to engage you all in this conversation. And hopefully by the end of the conversation we may be able to determine whether we can turn this momentum into something that's tangible and we can feel, touch, and makes a real difference to people with lived experience. And to yourselves, for those of you who joined early, you heard me use the language busy times. There's an enormous amount of competing priorities. Some of you here will commission services. Some of you here will be researchers. Some of you will be here because you have a real vested interest in delivering great frontline care. Some of you will be here because you've got lived experience and you want to see improvements continuously. Some of you will be here from agencies that include HMPPS, recovery, NHS. That's great. We've had, I think, over 170 people register. We'll be recording this today. And therefore, for those who perhaps would have loved to be here, but for whatever reason can't join, we will make sure that everybody who's registered has a copy of the slides, and we'll be putting out the information openly and transparently so others can get involved in the conversation we start together today. So if you could move on to the next slide, colleagues, and I'll just walk you through the event. So in a moment, I'll go through some housekeeping, some formal housekeeping, but I just want to indicate that we have a busy schedule today, and we are going to have to do a little bit of clock watching, but we appreciate we put a little bit of time in this event, which we can catch up if we need, because I don't want to shortchange any of the amazing presentations that we have today. But you can see that we have front-loaded the afternoon into some conversational presentations to you all, giving you information. Some of it for you it might be a reminder, some of you it might be something to resonate. Get your brain cells thinking about what we're saying to you means to you. And after the break, and after I've introduced Mike and your perspectives, Mike, we will move out into some breakout sessions, which the usual Teams magic will take place. We've got up to 10 sessions scheduled because we think we're going to need them. And we will need people within those breakout sessions to step up, identify a facilitator, but we'll guide you through this. But I just wanted to create that balance for you between listening, connecting, thinking, and then in the afternoon a chance to talk together and share together before we round it all up and actually collectively agree on some next steps. In the chat, we will have an opportunity for you to do things that you might want to do. Ask questions so that we can collate and review them. Affirmation statements, testimonials, observations, energy, anything that you want to create in the chat, we're up for, because again, we can make the chat available, we can thematically stratify it and share it back to you as part of the event. And I think please do use it, and it demonstrates to me as well the energy, and I can get a sense of what you're all thinking in the room as well. So hopefully, as you've read that whets your appetite and you feel you're in the right room and you're wanting to join. Dame Carol, if I might openly ask you, are you able to join us for the whole of the session? Because if you are, it changes what I can do with the event.
No, I am. Yes.
That's fabulous, because we've got a packed agenda, and it means I can collect the questions up, and we can actually make sure we're available to you at the end of the session to answer questions, and all of our speakers, including myself, will be there to converse with you. And I'm very, very conscious, having had a quick sneak preview of who has signed up, we've got a number of experts in the room as well, and I'm really keen to get your advice and your thoughts as well, and your contributions, because expertise is shared. There's a breadth of it nationally. So without further ado, and because we're on a tight timescale, I really want to get started, if I may. But I want to just check with the housekeeping. You're all doing what you should be doing anyway. Just keep your microphones muted if you can. I've talked to you about the observations and questions in the chat. We'll be looking at those and aggregating them. We will give you a comfort break so that you can grab that all-important warm or cold beverage. And then just that notice, colleagues, that we are recording, and that you be mindful and respectful, because, as I said, we want to make this conversation transparently available to colleagues. If any of your tech freezes, I've always found turn it off and turn it back on again never fails, and it usually works in these kinds of scenarios. And all of my team here in Spectrum are here to support you with that. So just let us know in the chat and we'll attend to it. Brilliant. So it's an absolute honour to welcome Professor Dame Carol Black to you all now. I've had the pleasure of knowing you, Dame Carol, for many years. I understand and benefit from the fact that you're now a leading authority on addiction recovery and the public health element of that as well. And Dame Carol's influential reviews have shaped national policy, and they've brought vital attention to the role of prisons in supporting recovery. And today, Dame Carol will share her insights on minimum standards in recovery in prisons and continuity of care, and also share some of the findings of her recent prison review. Please join me in welcoming Dame Carol Black. Professor Dame Carol, thank you. Oh, you might be on mute, but
No.
We're here. I can hear you, Dame Carol. Yep, we can hear you.
Tried to move my slides on, but wasn't able. So I don't know whether. Okay, why don't you just move them on? Look, I'm delighted to be here, and as you say, the important thing really is to hear from other people. I'm partly just going to set some background, but we're really here to talk about minimum quality standards for healthcare recovery in prison. I'm just going to remind you, first of all, that I did my independent review of drugs, and you will remember, I hope, that prisons were excluded from it, which was a great pity. I didn't understand why at the time. I understood later, but it would have made really more sense to have included prisons at the same time as I looked at the community, because the two things are so interrelated and dependent on each other. Good care in the community means less people going to prison. Really good care in prison means when people leave prison, they are scooped up back into recovery systems, given a holistic care, and don't necessarily and hopefully need to go back to the secure state. You will remember that I found most things broken when I did my review, and in the next slide you will just see the recommendations just very, very quickly. It was about creating a whole systems change. You can see in all those squares the things that we needed to put together. This had to be cross-government centrally. It had to be cross-organizations locally through partnership boards. And the two areas, the central and the local, needed to relate closely to each other. There needed to be accountability. So a whole system change, but obviously needing underpinning by essential additional investment, which we got 780 million over the period of the 3 years of the spending review 2022 to 2025, and now of course we are into a 1-year spend, and then there'll be the 3-year. And hopefully in that period, people will know what money they're going to get for the 3 years. So this is roughly what I was trying to achieve. It was coordination, holistic, in which recovery in the community was an absolutely essential part of what I was doing. Next one, please. Some good progress with my recommendations. I mean, I won't say to you that everything has been successful. That would be foolish. It has been much more difficult changing culture than I ever anticipated. People were demoralized. They never really thought it could be different. They'd been through a terrible period of austerity. Much had closed down. And it was a question of rebuilding, but also rebuilding trust. Lots still to do on workforce, on the quality, on drug-related deaths, we've started to develop supportive recovery communities. So much more to do there. Some improvement on housing and rough sleeping, and a really good piece of work with using the IPS model to enable drug-dependent people to find sustainable work, and some money going into research. And I was commissioned, after I published the independent review, to do an internal review of drug treatment in prison, which to start with was internal, but after I gave evidence to the select committee, the Justice Select Committee, is now in the public domain. And that's what I really want to spend a few minutes talking about. So next slide. So this is just the way I did it. It was a very rapid review. We were only 3 members of the team, so we were an extremely small team trying to do this piece of work, commissioned by ministers in the previous administration from Justice, Home Office and Health, to review treatment and recovery in prisons in England, to assess the current situation and the ability of the prison service to contribute to the very ambitious drug strategy which the then government had published in December 2021. So we did our best to gather national data. We visited lots of prisons. We spoke to lots of people. We interviewed many key stakeholders, including lots of people either who were in prison or who had lived experience of being in prison. We obviously talked to commissioners, probation staff, prison staff, the independent monitoring boards and the judiciary. And we visited several prisons, and we were able to get data, perhaps not as much as we would have liked, but we were able to get data to substantiate findings. To put up right up front the ambition that there is within the prison service, and the services provided, as you will all know, by NHS England, to really do the right thing. I didn't meet anyone who didn't want to do the right thing, who wasn't keen to make a helpful intervention. And if you look at the NHSE National Service Specification, I really am very happy with this. I wouldn't want to improve it particularly. It says the right things. It talks about psychosocial interventions at entry, continuing availability of recommended evidence-based pharmacological and psychosocial treatment during imprisonment, with systems for the management of mental ill health, care and risk management planning, and continued service provision on release and integration back into the community. They are the things that everybody wants to see. So what is aspired to, what is written down, is very, very acceptable. Did I find that? Sadly, no. And on the next slide, you can see we really divided the report in a way into the commissioning structure, what happened inside prisons, and then release. And in each of those three areas, and it would be silly of me to read all these slides to you, we found things that we wish to see improved. So the commissioning structure, because of its very nature, from the centre of NHS England through to regional commissioners, down to them commissioning a major health provider, down to that provider then securing those who will provide the drug and alcohol service in prison, there is a very long journey. And we felt it was a journey which had no consistent clear line of sight of responsibility between all those players. So there was a lack of common targets, which you would want, because you would want there to be shared outcomes. And we tried very hard to look at the financing. We managed to secure some information, but we did say that the actual the amount of money spent on drug dependent care in prison, particularly on the mental health psychosocial component of that, we wish to see more clearly. So a lot to do in commissioning. My personal view is that commissioning the care of drug dependent people is different from commissioning, let's say, the care of general practice or ophthalmology or hearing problems, because if you get it wrong with drugs, it causes enormous societal harm afterwards. And then inside prison, we found both overstretched, overworked prison officers, probation officers, really with no particular attention to the drug dependent population, or indeed knowledge of them. And you just got this sense that it was so hard and difficult to keep the show on the road in overcrowded prisons. And these individuals were not seen as the most difficult, if you like, of the prison population. Treatment was very formulaic. I'm very happy in questions to go into that in greater detail. I wanted a much more personalised system, much greater availability of Buvidal, and really there was not a timely delivery of psychosocial interventions, mental health, and very little trauma treatment. Release, I think I could summarise by saying so many, I think we had 6 or 7 bits of the system all trying to be helpful, not communicating with each other electronically, and therefore it was very easy for a prisoner to fall through the cracks. We felt it could be improved, and we also thought that the new national outcome framework, which is relevant to the community, and the commissioning standards, there should be an equivalent for prisons, and why not use that which we've just developed rather than reinvent the wheel. Next slide, please. Just again, so you can read it, just some of the recommendations in the commissioning and the accountability part. You will note that I was not specific about what ought to be the new way of commissioning, because I felt this needed a lot of thought and care, and it should be done by NHS England communicating with the prison service, with the local community service. It should be those people sitting down together deciding what was the best way of commissioning this particular service, and that there should be much stronger links with the ICBs and the partnership boards in the community, which were there for the community services. And also needs assessment needed to be much more routinely and uniformly done and taking evidence from the services. So it ought to be people sitting down deciding what the commissioning should look like. Then when we come to next slide, inside the prison itself, this is of course where I didn't see much recovery. I saw a lot of formulaic delivery of methadone. I saw lots of people in queues. In a few places, I did see very good practice. And when the ISFLs worked well, I saw some very good practice there. But overall, as you can see here, we would recommend improving the prison environment and culture and the training of prison officers about the real complexity of drug addiction. I would love to see a personal care plan owned by and accompanied prisoner through their journey, and that the whole journey be one which incorporates a proper recovery program. Not just let's give you your methadone and let's hope that the many months pass by and then you'll be released into the community somehow better or okay, when so much good work could be done in prisons. After all, people are there 24 hours a day. They are there to be helped, to be supported, to be enabled to find a different way of living their lives. Lots of comments about the caseload, which was often like 80 cases, 35 would be what one would wish to see. Very difficult to get in mutual aid and peer support. Lots of good reasons why the prisons couldn't accommodate it regularly and easily, but something that absolutely needs addressing. And I felt that drug treatment should be a purposeful activity and rewarding patients for it. I did visit one women's prison. I didn't do a great deal of work on that at the time because NHS England had commissioned a report on women's prisons, and I liked what was written in that report and felt the best thing I could do was to support what was found there and not try to add any confusion to it. Next slide. I've only put this slide in, it's a very complicated slide, but I just wanted you to get a sense of the number of either key workers or organisations we found inside and outside a prison responsible for a prisoner's release. It's just too busy. It's far too complicated. There's maximum opportunity for people to fall between the stools, between the probation staff inside the prison, the probation staff outside, PNAP, the prison's misuse substance service inside, NHS Reconnect, health and justice coordinators, etc., a digital passport. I found it very hard to understand how all of these connected to each other, and I did suggest a much simpler system because, again, you wanted the individual to be able to leave the institution and move into holistic support, which was very recovery grounded when they left prison. Next slide. And you will see here, therefore, some of the recommendations. It was about making information much more shareable, etc. And we would have agreed with Charlie Taylor that the offender management in custody model was not seen in practice. And the next slide, please. These were just some of the voices of the prisoners. They had a very clear view, many of them, of what would have helped them, what could have made a huge difference. and much of that was about really getting good, quick access to psychosocial support, to trauma support, to being supported to get some purposeful activity, to be able to have access to peer workers and mutual aid support. We commissioned a piece of extra research so that we could get the multiple voices of those in the secure estate. And the last slide, I feel really very strongly that the prison system and the community system are very linked systems. So they ought to be as seamless as possible. They are not two foreign beasts in different parts of the world. And if you cannot give hope and good treatment and recovery in prison, then it will be very hard to enable those people to think it's available in the community and want to go into a treatment and recovery outside of the secure estate. Equally, if we don't do a good job in the community and we don't provide high quality care with all of its elements, then people often will not stay associated to recovery or treatment. They will be much more likely to commit offences and to be back in the secure state on that dreadful hamster wheel that does nothing to help anyone and is highly destructive, in my opinion, of life. So that gives you a sense of what I saw there, and I'm very keen to participate in the discussion that's now going to happen in a few moments on quality standards for healthcare recovery inside prisons.
Thank you so much, Dame Carol. I mean, it's a privilege really to hear these insights, for them to be presented so succinctly back to us, and we've got some, already some insights, some testimonials, and thank you for the questions. Do keep them coming. There's so much in there. For me, as somebody who's been a clinician for a long time, listening and hearing those what are really clear and very hard-hitting recommendations, but it's really the knowledge and understanding, and it was a pleasure to be part of your visit to HMP Style. I remember sitting with the women and listening to their voices, because we need to be grounding this in lived experience, and it's also grounded in your personal and real professional observations. Thank you so much for setting the scene. There's so much ambition in this, but I'm already sensing there's a bit of a call to action here, which is one of the reasons why, and then it sort of seamlessly moves into the sort of next opportunity I have with this audience of 170 esteemed people, is to start the conversation about what would the process of generating minimum quality standards for healthcare and recovery in prisons actually look like. And I think, Dame Carol, you've also made it quite clear that this isn't just about what's behind the four walls or the barbed wire. This is very much about that seamless relationship to care beyond the gate as well. So with colleagues that are here listening to this and thinking about this, I just want to make that point really clear, because that's where I'm at with this. In the interest of timing and keeping this going, I'm going to now as well introduce my colleague, Professor David Best, who's going to co-lead this presentation with you, which is a series of ideas that we've pulled together. And I've known David for some time. I first met you, I think, when we were working on the Orange Book Guidelines together, and I certainly can't shine the light. Many years ago, yeah. There's a theme running here, isn't it? Years and age. But I think obviously in the recent years, been able to, and particularly in the most recent months, start thinking about learning from you, in fact, in relation to the huge contribution that you've made to evidence base around recovery capital and the research base. So that's been a great discovery journey for me, and I'm delighted to be able to share the stage with you in talking us through our concepts to you all today, and to get your thoughts on it. Next slide, please, Sarah. So just a little bit about why. So I hope that this this leads nicely on from Dame Carol's really strong evidence-based work that she so succinctly shared with us. And this is about hope. I think Dame Carol mentioned hope. This is about hope. Hope for the people we care for, the men and women in our care. Hope for the practitioners and the leaders as well, because we want to get out of bed and we want to see impact in the work that we do. And we are making a difference, but we want to increase that difference. And I certainly don't want to compromise anymore in relation to how we do this. I truly want to be part of a recovery-oriented treatment system that's universal, and that where there's as much as possible one single version of what that truth could be. I see my role, as I'm sure all of you here that you've spent time to join, as being part of making Dame Carol Black's review recommendations come to life alongside the National Drug Strategy. And that includes aligning with all the current reforms that are going on around the Ministry of Justice, Public Health, NHS England, Department of Health and Social Care. It's a really busy space, and there's a lot of reports being generated at the moment that we want to make sense of and line up. I want that recovery model to be relentlessly based on good practice and evidence. And I'm very conscious, and I won't know all of you personally that are on this call today, but for those that have joined from the organisations I have the privilege of working with in partnership or in collaboration, I'm very aware that there are some sites that will be really keen to be early adopters really and driving forward a model going forward. And one of the things that we want to imbibe in this conversation is, are there early adopter sites out there, individuals that would like to be part of a community of practice and really drive the momentum forward? Because, as I said, we want a coalition of the willing. It's really important we try to streamline efforts across HMPPS, the NHS, public health lived experience. We're very diluted, we're very busy, we're very stretched, and we're likely to be moving into a period where we're going to be more stretched. So really making every contact count is vital, and therefore it's really important that we streamline our efforts, we don't duplicate. And actually we're going to have to improve productivity. And I talk to lots of staff in my role, and I'm often having conversations about how do we do more with the same, or quite often more with less, and actually how can we unlock the assets that we have. And I really believe that one of the way of doing that is to pool them more effectively and join them up together and reduce what could be some waste in the system, because we're perhaps doing things twice. Or even more than twice. And I'm going to mention lived experience lots of times because I don't want to pay lip service to that. And this is where I think, and I know when I hand over to Professor David Best, I think that, you know, there are many people who can speak more than I can on how important lived experience is. And the other thing is data. We put data at the bottom, don't we? But actually it probably should be at the top. I have the NHS plan on a page sitting with me. I take it to bed with me at the moment to try and understand, and I'm aware of the big bets, you know, data-driven approaches, artificial intelligence. This is a really exciting space, and therefore actually when Dame Carol said it was difficult to find good data to inform whether we're making a difference or not, this is a project that I would really like to address that. Next slide, please. I'm not going to go through all of this, but I've shifted my language a little bit. I'm a GP by background, as many of you know, but I've actually spent most of my career trying to work out how you can remove medics from the system and shift from a medicalized model to a non-medical model. And I've shifted now to thinking more in a model of care where we sit down in front of our patients, our lived experience with our colleagues, and think about the things that are wrong with people, and actually how can we shift to a situation where we're talking more about what happened to you, and therefore naturally fall into a more holistic, trauma-informed approach, one where lived experience is embedded. We really integrate. By integration, that is agency-wide integration, just not integration within the areas of work, whether that's different departments of state. A real focus on outcomes, and I'm still learning about how we move from output focus to outcome delivered care. We have to start learning from each other. I particularly want to be working in a way that actually actually we are open-armed and sharing, and that includes training. Lots of people know that I've spent a lot of my time investing in training, and I like to be involved in training where I'm not just looking at doctors in front of me or nurses in front of me. I'm looking at real a multidisciplinary, multi-agency team. Why don't we train more together? After all, we have to collectively resolve these issues together. Next slide, please. So this is a project. We don't have anything more than the energy in the room to go with at the moment. We are keen to determine how we might resource such a project so that we could actually turn what's in our heads and our ideas and some energy into a reality. If we are able to get this off the ground, we're determined that this is a whole prison approach and that it demands of us all to look in collectively, and that it has lived experience genuinely, not tokenistically involved in co-production. We're very cognizant that HMPPS have a really fantastic national drug and alcohol framework, and later on today we're going to talk about that. We want to build on that. We want to align with that. We're conscious there are conversations going on in NHS England about the specification for substance misuse recovery. We want to align with that and draw these things together. And we want to, with the early adopter sites, and thank you for, please keep all the energy coming. You know, this is not an exclusive club we're looking for. We're looking for a big coalition of the winning, with anyone who sees themselves as ready to be an early adopter, to be signed up to be a trauma-informed recovery advocate. We are a trauma-informed organisation in Spectrum. We're signed up to the Charter Mark in West Yorkshire ICB, and I'm a big advocate of the trauma-informed model, which imbibes strength-based working and digital. We want to create data from the outset, which will mean being collectively signed up to modern online monitoring methodologies for capturing data. Most of us are using Power BI when we're working in primary care, community, acute trust, local authority settings. We want substance misuse recovery to be aligned in its ambition, and I'm sure that's very possible to do. And recovery capital, again, I'm learning about the whole concept of recovery capital, but wherever we're building recovery capital, we want to be able to track that we're building on that right through the systems of work that we're delivering into. So that's not just behind the gate, that's through the gate and beyond. Next slide, please. We have some outputs. We don't want this to be something that we just talk about. We want to actually have an output as a result of this, so that when we bring whoever wishes to go on this journey with us together, that we actually have at the end of it a clear blueprint for a whole prison multi-agency recovery model. We want to have at the end of that something that has demonstrated how we might begin that all-important shift from medicalised, transactional experiences of care to something that's truly trauma-informed and strength-based, that's person-centred and evidence-based. We talk about this all the time, but I think in all of our day-to-day work, not for the want of trying, all too often we don't see and experience this in the way it feels to work as a practitioner. We want to also have at least cracked a methodology for how we do genuinely share our training assets, so that we commit to that one workforce for recovery, and we're not training and developing things in silos and doing them multiple times, because again that would crack some of the waste issues. Later on, we're going to introduce, for those who don't already know, one methodology for generating a means of tracking impact through the system, and Professor David Best will talk about the RECCAP tool. It might be a reminder for some, might be an introduction for others, so that we've got something in that blueprint that can genuinely test a hypothesis that I believe that strength-based care will improve recovery outcomes. Next slide, please. And I'll hand over, if I may, to Professor Best.
Oh, wonderful. Thank you so much, Linda. And they have been long years since we first met, but I'm sure we're both blossoming. And I am absolutely delighted to be here. And I hope that the fact that Linda and I are working together on this is indicative of the model we are trying to convey, which is about very powerful, strong quality standards following in work that Spectrum has previously done in prisons around quality standards, with a strength-based, co-produced, lived experience focused recovery model. And that's a big ask. This is not a simple and straightforward task. And from my point of view, the transition to a recovery model implies various things, and many of them already happen in prisons where there are a number of strength-based initiatives. But the focus on a strengths model really does mean some very important things. Now, one of them is a much, much more visible role for lived experience, and a fundamental assumption of social contagion, which I'll say a little bit more about shortly, about human connection and the generation of hope. And as Linda has already said, one of the fundamental premises of what we do is that is hope for prisoners, but it's also hope for their families, for the staff who work in prisons, and for management. A strength-based model fundamentally relies on positive human dynamic. So I have been in the very fortunate position to really be involved in the recovery capital debate from very early on. The term was coined by two American academics, Bob Granfield and William Cloud, and I've been fortunate enough to work with Bob Granfield in the last year or two. They wrote a fabulous book called Coming Clean, where they studied a number of people who'd never been to treatment services, never been to 12-step, but had managed to recover without any external supports. And effectively, what they had was different kinds of resource they could tap into. And in essence, the concept of recovery capital is about that notion of what resources are required. And they defined it as the breadth and depth of internal and external resources required to support a recovery journey. And my first work in this area, I'd done a big study in Glasgow called unimaginatively the Glasgow Recovery Study. And I combined my data with data gathered in New York by an American academic called Alexandra Lodi. And we produced this document for the Royal Society for the Arts in 2010, where this diagram comes from. And this really was the first significant attempt to start the process of quantifying recovery capital. Why was that important? Well, I've been arguing and advocating for recovery for a number of years by this point, but in clinical and scientific circles, it was largely dismissed as wishful thinking, stuff about God and spirituality and hope and all those airy-fairy concepts. Well, what recovery capital did was offer us the chance to develop a metric that we could start to count. And we did this work for the Royal Society of the Arts in 2010. Earlier this year, my colleague from Harvard Medical School, Emily Hennessy, and myself published the Handbook of Recovery Capital, where we were able to demonstrate the huge growth in the evidence around this. And bluntly, we have three areas that we typically think of as the core domains of measurement for recovery capital. Personal recovery capital, which are internal characteristics like self-esteem, self-efficacy, coping skills, communication skills, and resilience. But what's important is they are the things that are almost the outputs or the outcomes of a recovery journey. It's the other two slices of the pie, social capital and what we originally called collective capital, we now call community capital, that effectively provide the scaffolding around an individual that affords them the opportunity to build those internal resources. We think of recovery as a social contagion, and where it passes from one recovery champion to another. And for those conditions to pertain, we require three things: that recovery is visible, accessible, and attractive. And as Dame Carol said earlier, one of the huge challenges around effective recovery provision in prisons has been getting 12-step groups or smart recovery groups available and accessible in prisons. Keith Humphreys, formerly one of the Obama's advisors on drug policy, has argued that the single most important step you can take for recovery in prisons is to have mutual aid groups accessible. So, and why is that? Because they show that recovery is possible. They provide a model and a mechanism to achieve it, and they create a sense of meaningful community. So to return to the basic question of what is recovery capital, effectively it's about the accrual of resources. And from our point of view, it's about the measurement of the accrual of resources. Next slide, please. Now, the next slide, when it appears, yeah, this is just wonderful. I always feel like putting this up is a form of art rather than anything to do with the science. However, I have a PhD student called Adela Bonaccio, who has done a systematic review of measurement of recovery capital. And what this slide displays is the range. Every spoke in this wheel is a domain of recovery capital that's measured by one of the 10 existing instruments that are used. The RECCAP, which is what I'll talk about here, is effectively represented on this graph by the black dots in the outer ring. In other words, each black dot and the label next to it is a domain that's measured by the RECCAP. So essentially what this diagram illustrates is that the RECCAP is more comprehensive than any of the other existing tools. Now, I'm going to go through some of the things about the RECCAP, and one of the things that I was involved in, you see there's also a pink circle there called the ARC, and the ARC is the Assessment of Recovery Capital, which I published with William White and Teodora Grushkova in 2012, and it was a 50-item questionnaire of personal and social capital. But there were two problems with it. It was boring. It was another research questionnaire. And then people would score 36 out of 50 and they would say, what does 36 mean? So we had to remedy in two ways. And as Linda said, one of the crucial developments from the ARC to the RECCAP was switching it to an online platform. What that meant was that the results were instantly available, and I'll come on to the results shortly. The results were instantly available and it created a process, and I'll come on to that process in a minute. The next slide, please, Sarah, is essentially just for anyone. I expect nobody to read this, but what I wanted to say is the traditional criticism of recovery that rings in my ears is there's not an evidence base. Well, here are 12 publications just about the RECCAP. And we actually have page proofs for our criminal legal system paper, which we'll add to this graph shortly. But the point here is, this is now a well-evidenced model. In total, we have more than 22,000 completions of the RECCAP. 22,000 is not insignificant, because what that implies not only is it a validated, standardized tool, but it's highly acceptable. It's highly acceptable to the people who administer it. It's highly acceptable to the people with whom they are working. So we work in one jail in the United States at the moment called Chesterfield County Jail in Virginia, but primarily this has been done in recovery residences in America. Okay, next slide, please. So when you complete the RECCAP, as soon as you hit the submit button, and it can be done on your phone, it can be done on your laptop, it can be done on your iPad. This is the kind of score visualization you get. A traffic lighted score visualization that sums up the 7 areas of measurement that the RECCAP covers: quality of life, barriers, unmet need, personal capital, social capital, community capital, and motivation to change. And each of those donuts or bars represents a subdomain of one of those categories. We have it all in one page so that both the participant and their recovery coach can understand and quickly visualize what are strengths. And part of a strength-based model is you use strengths to build strengths. And it's been fundamental to this approach that we think of this as instead of assuming that our job is to identify all the flaws and deficits people have and ameliorate or remedy them, the assumption here is the long-term goal of a recovery journey is fundamentally jobs, friends, and houses. And as Linda articulated, our long-term goal is to help people move through that process of change. Next slide, please. And I'm sorry for the kind of bombardment with graphs. And crucially, at an individual client level, we're able to show as a kind of assessment history over time of the transitions. And you'll see in the example here, the bars at the bottom are, the red bar is barriers and unmet needs. And you can see in this example, they go down. And then the barriers at the lines at the top are effectively more strength-based personal, social, and community recovery capital. And in essence, what this allows us to do is to track the growth of well-being over time. In both drug courts and in recovery residences in America, this is done on a 90-day cycle. So effectively, you have quarterly reports. And the last thing I'll talk about is how each of those reports should fulfill what Dame Carol suggested. This constitutes the basis of an evidence-based and strength-based recovery care plan. So this is the idea, map and measure over time. Next slide, please. And because we have 22,000 completions, we're able to show typical normative patterns. So where somebody or where some service deviates significantly, we can show that they either have particularly good strengths or particularly significant barriers and unmet needs that need to be addressed. This is based primarily in recovery housing, and you see we've been able to create a very strong evidence base. And this work, the work around the RECCAP, is now cited in ASAM. So recovery housing, the National Alliance of Recovery Residences, has used these data to evidence that recovery capital grows as part of a funding package for recovery housing in the United States. Just for a minor issue of detail, males have slightly higher scores typically than females, and that remains consistent. Next slide. And going back as far as 2010, Granfield and Cloud identified 4 factors that they considered to be negative recovery capital. A history of significant mental health problems, an experience of incarceration, and perhaps more contentiously, female gender and being older. Because we have such a large database, we were able to test those factors. And having none or one of those factors gives the highest scores at both baseline and at the third follow-up point. But you will see with each one of those factors, somebody has from 2 up to 3 in the pale blue line at the bottom. Older women with a history of incarceration and mental health problems start with the lowest levels of recovery capital on entry, and that gap has actually widened by the time we get to their third follow-up assessment. They are still improving, but nowhere near as much. And this gives us the detail to say, look, we can show that recovery capital works as a metric, but it has the sensitivity to identify risk populations. Okay, and for the next slide, and I apologize that I stick with graphs and charts, I wanted to show some data from our criminal justice work in the United States with the RECCAP. So this is based on drug courts in Montana, Washington State, and Georgia. And you will see again here that there are clear and consistent improvements in recovery capital over time. What we've been able to demonstrate is for people who are engaged and retained in recovery supportive services inside and outside the criminal justice system, there are significant improvements in their recovery capital. Next slide, please. And very briefly, I wanted to show something similar from a Scottish project called the Lothian and Edinburgh Abstinence Project, which was originally set up in the Road to Recovery policy in 2008. And again, what we're able to show here is that for the first 4 charts show the growth of strengths. The last chart shows the reduction in barriers over time. And effectively, what we're able to demonstrate with the RECCAP across a range of settings, and it's now used in Canada, New Zealand, Australia, America, and to a much lesser extent, Ireland and the UK, is these consistent patterns of sustained recovery growth. So this is a reliable measure. So it is a metric. And as my last slide, can we go to the next slide, please? I just wanted to make this point that the model is measure, plan, engage. Why is that important? Because this is not just a monitoring approach. This is something that's actively results in a co-produced care plan with the client for the next 3 months. And so it creates a cycle of recovery care plan based on data. Recovery capital led, data informs care plan, that's then reviewed and a new care plan is developed, partly based on goals set and goals achieved. This to me is crucial, and our basic model for this is that recovery capital is a strength-based metric that will underpin our attempts to show client growth and well-being as a fundamental component part of establishing a recovery-oriented set of quality standards for recovery in healthcare and prisons. I hope that's not been too much death by graph and chart, and I'm happy to hand back to Linda. And next slide, please.
Thanks very much, David. I've seen that several times now, and I'm still sort of feeling really bathed in the concept. Okay, so we come here with a concept. It's very easy, isn't it, when you think about the extent of the challenge ahead of us? How could we make a start to work together as a coalition of the willing to be able to go on a journey together that would show that we'd made the changes that we have such ambition for? And we're here to propose just a methodology for transformation. It's not the only way of doing it, and now we've got so many more voices and so much more energy sort of collectively looking at this. There may be other ways that people can think, but we see this as the potential for a top-down and a bottom-up approach. We would like to work with a number of partners to start to put into place some kind of maturity matrix that would evidence collectively that we have a starting point, which is the here and now, point A, a shared understanding of ambition and a collective desire around output. And then we have a mechanism of measuring how much we're making progress towards our desired place, our desired blueprint ending point. We haven't written the minimum standards yet. Why would we? Because we're committed to co-production of that. The actual process of getting to that blueprint is part of this journey and is part of that cultural change. So we need to somehow create an architecture that's going to help us co-productively develop a set of minimum standards that we're comfortable with and that we can then measure our maturity against as a collective system. We initially, in the conversations David and I have been having, we wanted to start small. You know, are there 4 individual prisons that might want to throw their hat in the ring to become part of that early adopter methodology? It may be that we can think bigger than that and that we can create an architecture that has many more individuals, or we may be able to have phase and layers of a project where we start with a small suite and then we build on that over time. We haven't put the meat on the bones on that, but we absolutely acknowledge that busy frontline professionals and people of equal value with lived experience voice, busy in the lived experience space, will need support. So some form of central project team approach will be needed, and that might be possible to be put or stood up in a distributed leadership model. I've had experience of doing this way of working successfully in a lot of other arenas, not necessarily the recovery arena, but I have in primary care. And most recently, I'm working with HMPPS colleagues in developing the integrated standards for the management of people in joint care and separation. We tested that methodology of joint working very successfully there. And then the bottom up a bit has multiple components, but we see the RECCAP, and you've heard David describe what that could achieve for us in terms of measuring and the ability to measure and evaluate that we are making a difference to people's lives and we are creating that impact, would obviously come with a need for a commitment to some kind of system level adoption, the necessary training and the organizational development that would work through a community of practice. So we have put some thought into methodology. We'd be more than happy to be advised and about how we could make that even better. And I can see, please do put your comments. Next slide, please. Minimum standards and what a maturity matrix could look like. For me, those minimum standards are about a genuine trauma-informed, strength-based whole prison approach, which is why in developing them, they need to describe domains that are resonant and make sense and have the right language for all the agencies that wish to participate and should be participating in making this a reality. So it's not just using, I come from a healthcare background, a healthcare specific language. It is something much more broader than that. And therefore that minimum, that maturity that we want to see as a system will be our maturity in shifting from a more deficit sort of what's wrong with you approach to a more recovery capital what's happened to you approach. And I know from my own personal and professional development and from the people I work with on a day-to-day basis, we've got some work to do there. And I very much see that as being an integration model across HMPPS health lived experience. But actually, increasingly, as I think about this and get into conversations, and from my reading of the 10-year plan and work that I'm doing in other arenas on neighbourhood health work, actually, it's probably broader than that as well. Housing's been mentioned here today. We know there's an enormous role for the voluntary and community and social enterprise sector. And we propose here the RECCAP embedded as an evaluation tool. We've got some provisional thoughts about some core principles, things that would be non-negotiable for us around maturity. Our maturity in becoming truly trauma-informed in the way we work together. Our maturity in being good system leaders in strength-based recovery. And there will be things we will all need to learn to be able to achieve that. And our things we're not prepared to compromise around right care. So whether that's the clinical interventions or the psychosocial interventions or the social interventions, they need to be above the line, delivered by practitioners that are well trained and well supervised. Next slide. And I'll skirt over these if we move on to the next slide, because, these are just examples to give you a sense. What do I mean by how maturity could be measured and what the milestones of a maturing system could look like? We have to gather around something that we can all demonstrate distance travelled. And I've just used the language of, we will have systems that will self-assess themselves against the minimum standards and genuinely feel that actually we're operating at quite a basic level. Or there may be systems that feel they're a little bit further along that line of maturity towards developing a cohesive collective approach. And eventually the nirvana of maturity, where all of this thinking and change is truly embedded in day-to-day practice. So you can see the sorts of ways we might define that for trauma-informed care and the sorts of ways that we might describe it in relation to showing that we're maturing as system leaders around recovery-oriented care. These are just my thoughts and ideas. Others may come up with much better, more sophisticated methodologies to describe. But we wanted to put forward to you all a bit of a starter for 10, really, and then think about is this a good enough starting point if there is enough energy to take this forward. Next slide. And we can go on. I think I've talked about the principle. I'm just conscious of time as well. But eventually, what would good look like? What would be the defined collective measures of success? Well, there'll be something around achieved culture shift, something that demonstrates we're not silo working anymore, that we genuinely aren't working to a medicalised model. It's genuinely integrated and trauma informed. That we are operating as a system holistically. Interoperability, and I mean, we could go down a rabbit hole here around we still face an uphill struggle. I can just see in the chat through the corner of my eye some of the barriers and constraints we have genuinely around interoperable methods of sharing real-time information, whether it's interoperability between healthcare systems or between health and HMPPS or between health and individuals, you know, who come for care, you know, who've got phones with the NHS app that's increasingly going to be on their phones and other methods that they can use to access care. The willingness for us to share our resources. Money is tight. We understand that. There's not a day goes by when I'm not having conversations about that, but we do have a lot of assets, and possibly some assets and things we don't actually know we have, and if we were prepared to share them and have a systematic way of doing that, we may be able to find sufficient resource to make this a reality. And lived experience should be at the top, and there's a lot of energy from our lived experience colleagues and experts today about how we genuinely can embed co-production and make that a reality, and I wouldn't profess to know all the answers to that, but I'm committed to making that a reality. Next slide. So I'll stop there, colleagues. We had indicated here at this point that it would be a good time, because we've been talking for a long time, to have a break. And that break could take us to 14:50, 14:55, if at a push, for colleagues to just get a bit of headspace, a bit of fresh air if you need it, if you're in a room, have some thoughts about what we've said, and then we'll come back again, colleagues, at around about 14:50, 14:55. Do use the chat if you want to use, and I'll be introducing my colleague Mike Wheatley for the final presentation of the afternoon, and then a chance for us to have a conversation together in our groups. So thank you all for listening and for your comments. Please do continue reflecting. I'll see you at just before 14:55, just before 3 o'clock again. Do join us. Thanks. Thank you all. Thank you. We'll return soon.
Hi and welcome back, and thank you so much for joining us today and for coming back at this point in the agenda. Now, the more eagle-eyed of you will notice that it says on the agenda that the recap has been done by Linda, but it's indicative of how closely we now work together that I have in fact turned into Linda. We are one and the same person from this point onwards. Anyway, that aside, so I just quickly wanted to cover off what I think were 6 core themes that I think had continuity from Dame Carol's presentation, Linda's presentation, and my presentation. I think one of the things that very clearly was represented in Dame Carol's work was the sense that there is both inconsistent and inadequate current provision, that what we currently have across the board is not satisfactory. I think for any recovery model, but particularly given the circumstances in prisons, there's a clear need for co-production. We need to ensure adequate representation of all stakeholders, particularly prisoners. There's a developmental issue around training and staffing that we need to ensure there's enhanced support, and the model we're offering will provide a very clear guidance and structure for staff, but also bring staff together from different disciplinary and organizational backgrounds, and that's really important. As a researcher in this area for a number of years, nobody should be surprised that I'm going to say continuity of care is just crucial. We know everything to do with both addiction, treatment, recovery, criminal justice, that continuity of provision from prior to entering prison, while in prison, and post-release through the gate, continuity of care is essential component of effective provision. Fifth, I'm sure you will all have picked up, we cannot have siloed provision. We need a whole prison approach. And that whole prison approach has to be predicated on the strengths and innovations that are currently out there, and that we have managed to identify, but not consistently replicate and not necessarily scale. So those are the 6 key points that I wanted to make, but we will engage you in discussion after we've heard from the last of our highly esteemed speakers. Mike is a very, very young man, so this is Michael Wheatley from His Majesty's Prison and Probation Service, who's going to give us a presentation that really puts the policy context around recovery in the prison situation. So thank you very much, Mike, and over to you.
Thank you, David. And I start with the age theme as well by just going back, Linda, to some of the work that we did back in the 90s, where we kind of led the way with a pioneering drug court treatment program some 30 years ago. And some of the themes that we touching upon today were things that we've encountered then, and we continually strive to improve the system and to make contributions that I think will just strengthen recovery pathways and the treatment experiences for people in our care. And just as a bit of background, I head up the drug and alcohol group, which is part of HMPPS, which covers both prisons and the probation service and some of the provision. And I thought just today I'll give you some thoughts around, having heard what we've heard and looked through the challenges that we face and some of the issues that you're talking around in the chart, just to ask the question, or to pose the question, is recovery possible in the current prison system, given some of the challenges and some of the barriers that we face at the moment, and to look at how perhaps these minimum quality standards can make a contribution, and in fact, if it is possible to kind of contribute in this way. So Sarah, next slide, please. And just to set some of the context as well, to try and help answer that question and look at some of the issues that we're wrestling with at the moment. I just wanted to start by just setting the scene, really, and there's lots of data that we can call upon, and going back to part 1 and part 2 of Dame Carol Black's independent review, I thought she very comprehensively just gathered in as much data around the prevalence of drug and alcohol use, both within the prison system, but also touched upon bits in the probation system as well. The data, the stats that we've got here in blue, just shows that it's estimated nearly half of people coming into prison have an identified drug problem, and about 21% of those people coming into prison have an identified alcohol problem. We think these are a really conservative estimate. And again, within probation practice, there's a large number of people in the community working with the probation services that may have identified drug and alcohol problems, and we think this is probably an underestimate. And we could dwell upon all of the statistics and analyze it, but I think what it really says to us is that we do have a significant proportion of our population who we're working with in prisons and in probation who have issues related to drugs and alcohol that we really do need to kind of get on top of and to work with in order to provide the support and the opportunities for people to be able to recover because of the issues that they present. And we also know that drug and alcohol use has a number of different factors related to safety and security risks and stability issues that it introduces within our current prison system. And last week, Charlie Taylor published the HMI Prisons annual report. And I think I've just put a snapshot here. The opening lines are quite stark, really, for the current operating climate, where Charlie and the inspectors were saying that they were really overwhelmed by the evidence of the availability of drugs within our prison system and the destabilizing effect that that has on all of our regimes and all of the ways that people work within the prison system, and that these kind of are really important for us, and we need to get to grips with these and to do something that will help bring back that stability and help reduce demand for people's drug-seeking behaviour within the prison system. And again, next slide, please, Sarah. From a range of different reports, not just the HMIP, but also from things like the Independent Monitoring Board. And just even this week, we had a publication from the Justice Home Affairs Committee around prison culture, governance, leadership and staffing levels. These are a range of issues that have been identified for us that we have to contend with at the minute, and are kind of challenges that we have to face in order to deliver good treatment and recovery services within prisons. And again, I don't propose to go through, you'll get the slide deck and you've got these to hand, but some of the big issues that and the challenges that we face is around the contribution that drugs and alcohol use makes towards criminal behaviour, reoffending rates. The amount of drug-related deaths is escalating across the country and the communities, and that's having a high impact on us. We've mentioned some of the operational challenges that we face now, and some of the kind of curtailment in regime activity as a result of all of these operational challenges, which is making it really difficult for us to deliver the services that we need to deliver in prisons, to really optimize the opportunities for us to deliver good quality treatment and recovery services within the jails. There's some of the things that we need to do to, like we've talked about around having more support rather than punitive options within the prison system, and challenging some of the stigma that's associated with a lot of the attitudes and some of the language that we use within the prison system, in order to basically strengthen the recovery opportunities and developing this recovery model. So there's a lot of challenges that we do face within the existing system. And next slide, please, Sarah. And what we've been able to do to try and compensate for some of those challenges, because I don't want to be too pessimistic, because I'm an optimist by trade, really. There are a lot of opportunities for us, and I think the things that we're talking about today can help make a significant contribution. And these are some of the things that we've introduced recently, largely informed by the contributions that Dame Carol made towards the national government drug strategy and the investment that we saw coming from that. And the prison service certainly benefited, or HMPPS benefited from that, because we saw an initial investment of over 120 million that was given to us to try and strengthen our recovery pathways and our recovery orientation within the system. And that was alongside the 100 million that was invested through the Security Investment Programme, that just tried to strengthen the physical and the procedural and aspects of the of security and safety within the jails, that just help stifle the ingress of illicit items coming into the prisons, just to try and create that headspace for people who had drug and alcohol issues to be able to kind of deal with those issues safely and securely within our prison system. So we did see a big investment, and that's continuing this year. We got the investment from the spending review, and for this year's allocation, that's been rolled over. So we've seen a continuation of that, which has allowed us to kind of build on this infrastructure. And these are some of the things I just wanted to bring to people's attention of what we've done since that we've had that investment. One of the big contributions that we've made is, and this is largely a document that was devised for the HMPPS direct employed staff, but we've developed an operational framework which is essentially sharing good practice in line with what we have seen. Evidence tell us works more effectively to try and reduce demand and supply. But we've developed this operational framework, which I'll come on and touch upon, and we are implementing that across all of the prison regions at the moment, and working with area executive directors and prison group directors to look at how we can strengthen the implementation of this particular framework and give a stronger emphasis on building recovery and the recovery model within our prisons at the moment. To do that, we've been helping by building the workforce and the capability of the workforce. We've seen an expansion in drug strategy leads across the prison system. Initially, the investment allowed us to introduce 54 drug strategy leads across the prison system. We also introduced a range of drug strategy partnership managers and coordinators within the community, and they work closely with the prison system to ensure that continuity of care and that the kind of arrangements that are made within the community help support people coming out of the prison system. But our drug strategy leads, we currently, within this year's allocation, recruiting an extra 17 group drug strategy leads to build that network even further. And I think along with what we fund within HMPPS, prison governors and prison group drug strategy group directors has also been funding their own network of drug strategy leads as well. So we have about 122 registered at the moment on as a part of our network to just help with the implementation and the introduction of this recovery-oriented model within our system. So the workforce, we've been building capacity within the system to help us make the changes that we need to make to make the improvements that Dame Carol and a lot of the other people who've reviewed our system have been asking us to make. Some of the other developments that we've had recently, we've introduced incentivised substance-free living areas, these recovery spaces, recovery environments within the jails. So we've got now 85 incentivised substance-free living areas across the estate, alongside 6 dedicated drug recovery wings, which offer a more intensive support and treatment package to people with drug and alcohol issues as well. So those recovery environments have just helped us create the spaces that we need to support people better with who've got identified needs. Some of the other things that we've done within our group and within the HMPPS, we've established a task force now to help deal with the issues related to synthetic drugs, not just synthetic opioids, but also the new range of synthetic cathinones and other synthetic drugs that are kind of making its way into our system. Initially, we thought we were going to be heavily bombarded, as we had with the synthetic cannabinoid issues back in 2013, 2015. We thought synthetic opioids and other range of drugs was going to have a big impact, and it has led to a number of drug-related deaths across the estate, which has been really significant for us. But still, we anticipate that the synthetic drugs are going to have a big impact with us within the prison system. So we've mobilised a task force now that's working to develop a number of initiatives to try and prevent and monitor and help with the enforcement and restriction of synthetic drugs, and provide better advice to how we can deal with these and treat these kind of symptoms and the prevalence of these drugs as they appear within our system. And some of the big mitigations that we've used to try and deal with this kind of emerging threat is the introduction of naloxone now, the nasal naloxone program, to work alongside what was introduced through the NHS and all of the healthcare providers who have take-home naloxone and have introduced naloxone provision for a while now. But this naloxone provision is for HMPPS direct employed staff. Those volunteers who come forward have now been trained, and I think we've got the best part of 2,000 who are trained now to be able to administer naloxone in emergency situations. We've also seen the rollout of mutual aid support groups through the tele-recovery infrastructure to try and help provide better support for people with identified needs. And also we've put a range of different initiatives in place as well to try and strengthen continuity of care. And we've seen the continuity of care rates, which is measured by NDTMS, increase significantly, and we still have a long way to go, but we've seen some improvements by initiatives like the National Probation Action and Project, PNAP, being made. There's lots of other contributions going on within the community as well, and we've had the recovery-oriented approved premises and intensive supervision courts. So basically, there's an appetite at the moment to develop a recovery model and this recovery orientation. We're gathering more evidence. We've got a whole programme of work undertaken by our Data and Analytical Services division within the Ministry of Justice, and they're going to be publishing some reports later this year, which is really promising, particularly around recovery environments, around the contributions that they make to stability, but just improving recovery opportunities for people who are in those spaces as well. And we're using that research evidence just to inform our thinking and our future bids to make sure we get the funding that we need to be able to develop this further. Next slide, please, Sarah. So essentially, we've got a range of different interventions and initiatives that's going on. But what we find is that they need to be implemented effectively. And if they're not implemented effectively, they have very little impact. And so we've been with our operational framework looking at how we can strengthen the implementation and support implementation. This is where I think the things that we're talking around about the minimum quality standards really comes into effect, because I think if we develop these minimum standards, it makes the implementation of these services much more effective for us and creates this enabling context, the conditions, the right conditions for people to develop the outcomes that we want to see. And this is just a basic model that we're working on now. If we have these promising interventions and you effectively implement them, create the right conditions, then that leads to positive practice outcomes. And that's what we're working on within the Drug and Alcohol Group, and alongside STAR and Spectrum and other providers, to try and create the right context for us to get the most out of the opportunities before us and to build these the recovery model and the recovery orientation across the system. Next slide, please, Sarah. So this is just a quick snapshot of what we were talking around about the recovery-oriented system. This is our framework document, which we are circulating around to all of our staff. And this is on the HMPPS intranet, so people who have access to a Justice email account can go on the intranet and see this. But basically, next slide, please, Sarah. It has 10 objectives that we're asking people to implement, and 6 of these are orientated around recovery, 2 about reducing demand, and 2 about restricting supply. And these are just the 10 kind of critical factors that we've seen for prison group directors and all of our staff. Really, if you've got to create a recovery oriented system, let's just focus on these and let's just implement these really well. And this will help us create the recovery model that we need in order to do better with the offering support for those that are in our care. And I think the contributions the minimum standards will make will just help enhance the implementation of this particular framework and allow us to do better with the resources that we have. Next slide, please, Sarah. And this is just my kind of graphic that I put together to try and explain to people about what we're trying to achieve within HMPPS about getting a whole system response to be able to create this recovery orientation. And it kind of revolves at the centre of the system around building recovery capital. And David's already touched upon this in the 3 different elements. But by putting the services in place, the NHS commissioned the treatment services, what we've done to be able to create safer spaces within the prisons, and we still have a long way to go, that creates the headspace for us to do our work with the treatment and the recovery support services that need to be put into place to create this recovery oriented system. So central to this whole theme is around building recovery capital. And this is what we've been advocating for all of our staff to support our NHS colleagues, all work collectively together to create this recovery-oriented system. And for the recovery-oriented system to kind of have most benefits, we also need to work with all of our rehabilitative services, all of the justice capital as it's been touched upon. And David has worked and produced a lot of papers looking at and I know people have talked upon in the chat about desistance literature as well as the recovery literature. And there's a lot of overlaps and similarities. But with the recovery system, working with our wider rehabilitative opportunities related to employment and housing provision and the continuity of care arrangements that we've put in place, where people work together collectively, where there's alignment and integration, we're much more effective in being able to create this recovery-oriented system and give people the best opportunities to obtain long-term sustained recovery. And to be able to deliver this alignment and the integration, leadership is critical. The management within the prisons need to be understand what's required of the system that we're trying to develop, and have those difficult conversations with staff members and also the prisoners themselves, to have them actively involved in the development of all of the services as well. But this outer layer of leadership, management, staff involvement and prisoner involvement is critical for us to be able to build this recovery oriented system and be able to get the outcomes that we want to achieve. Next slide, please. Sarah. So our vision within the HMPPS is that we do believe, and we go back to what David and Linda were saying, this is all about hope. We do believe that change is possible. We want to strive to create a system now which allows hope to flourish and prioritises people out of their problematic drug and alcohol use and into long-term sustained recovery at their earliest opportunity. So having the standards that we're talking around producing and developing now will help us achieve this particular vision. And it's not just something that happens overnight as well. This is a long-term plan. So we're just doing the bids at the moment for the next spending review, which takes us through from 2026 to 2029. And we look to basically get additional funding to develop the system even further, to create this recovery model where we provide support to all people in prisons and on probation into recovery pathways and out of the life of problematic drug and alcohol use in their offending. And we want to introduce a number of opportunities and measures that will enable us to demonstrate that we are creating these practice outcomes, these benefits for the people who are in our care. And we've just listed some of them there. But these are things that David has touched upon in the presentations with Linda as well. But things like we want to have personal recovery plans for everybody who come into our system, so they have a clear identified pathway from prison back into the community that they could follow, that just gives them that optimizes those opportunities for them. And also increase the number of people who are going into suitable, sustained accommodation, have education and employment opportunities opened up to them, and also get the support from their wider family and society just to be able to sustain and build that recovery capital. And we want to measure that through things like the RECCAP system that David's talked about, to be able to show that we can create this recovery orientation and develop the benefits that we need to put into place. So next slide, please, and I'll quickly wrap up. And this is a shameless plug. But as well as David's book that we touched upon earlier on, we've also, with Recovery Connections up in Middlesbrough, created a new publishing house called New Central Media. And one of the first couple of books that we pulled together was this one about recovery capital and pathways through prison, where we pulled together a number of people who've been through prison and were in long-term recovery, and asked them to just give us their experience and to write about their experience of what made a difference. And those experiences, those stories that people are telling in the book are really kind of pivotal. And this is just a number of experiences that have been told. We've now got thousands of experiences that demonstrate to us, to answer the original question, that recovery is possible. It does happen, but we need to do better, and we need to do more, and we need to, and I know we've touched upon it in the chat. People say there's lots of recovery opportunities within our prisons. We need to raise the visibility of that. So all of the people coming in, not just the prisoners, but also the people who are conducting these reviews, see what recovery opportunities are available, because it does happen. There are good pathways in place, but we can always do more, and we can always do better. And I think, just coming back to the things, recovery is possible, but hand it back over to you now then, David. When we're talking around the minimum quality standards, HMPPS really welcome the opportunity for us to co-produce and to develop these further, because I think they'll add real value to the outcomes that we want to generate, and to the people in our care, to give them the support that they need to maximise the opportunities that's available to them.
Wonderful. Thank you. Thank you so much, Mike. That's just fabulous. And I hope for everyone out there, you're picking up the clear coherence and consistency of the themes across all 4 of our presentations so far. By all means, do buy Mike's book, but only after you've bought mine. Right, where we're going now, this is a real challenge in terms of the least technically competent person on the call, me, is going to introduce the next task. So if we can go on to the next slide, please. We're about to get you to go out into breakout sessions. So it's 23 minutes past 3. You, by some process of magic, you will be allocated to a group. Can you please, as soon as you're in the group, can you identify a spokesperson or a facilitator? Because at the end, we'll ask each group to feed back. So if you can nominate somebody, and we want you to spend approximately, once you've introduced yourselves, spend just about 10 minutes asking the backwards question of what are you aware of in your working world, whether that's a prison or not, that would be a good building block for recovery-oriented quality standards for healthcare in prisons. Having done that, the second 10 minutes you should then spend on what do you think our initial steps should be. Once we've done the sessions, we'll get your feedback, then we'll wrap up with some questions and answers and some reflections, and we are so grateful for your time. So magic will happen now, and you'll disappear into a group. Thank you so much for coming back and for taking part in the discussion groups, and we hope you had useful conversations. We hope you have made some useful new contacts, and we now want to get on with trying to get your feedback and thoughts on our 2 questions. And the 2 questions are up on the screen at the moment, and I'm going to just ask each group in turn, so I hope you know which group you were. So we have rooms 1 to 10, and I'm going to ask for feedback just in that order. And what we're also going to ask for is, sorry? Oh, I don't know if that was accidental. Anyway, we're going to ask for feedback from each of the groups. And what we're going to say is, can you try and cover new ground? Because we're on a fairly tight schedule. So if things have already been said, don't repeat them. Just talk about anything new that you've got. So wonderful. If we can start with the spokesperson for room number 1, please. What are you aware of that's working well that could contribute? What do you think we should start with as first steps?
So I want to think on my feet. We haven't numbered the rooms, so I just wonder if all the spokespeople could raise their hands, in which case then David will know who to go to. So if everyone who is a spokesperson could raise their hands, David, that gives you an idea then hopefully, and that we should see who the hand raisers are, and
Perfect.
We can go to them.
Thank you, Linda. I thought we could have been here for a while. So we're going to start with Matt Wall, if that's all right. Matt, over to you.
Hello. We had a varied and very productive discussion. We
Excellent.
talked a lot about building on the ISFLs as a real rock that activities can stem from and things. So that was a positive aspect. We looked a lot about the stability of the staff, the motivation of the staff, and the training of the staff as being a very important building block. We did reflect back on the NHS minimum standards document, and Dame Carol Black talked about that earlier, about the fact that actually it's pretty much fit for purpose as well. It just needs to happen. So we're really, really taking that on board. Look, as we move forward in making this kind of thing happen, we need much better integration between the prison and healthcare as well. We need shared electronic systems. So NOMIS, Delia, System 1, you know, people are recording on different systems and there's not a joined up approach. We also need more shared accountability and commissioning so that, you know, one hand knows what the other hand's doing and can hold each other to account. So information sharing agreements are really, really important there as well. And we need targets and prioritize. So often I work for drug and alcohol services. So often our rooms get pulled because another activity like education that has a KPI attached is seen as more important. So we need more support for things like that. We also need it to be more easy to have employed staff who have lived experience within the prison, not just volunteers and things like that, but actually members, for example, of the drug and alcohol recovery team. So hard to get paid staff with lived experience, and it affects the whole dynamic. Just quickly, a couple of other things: much better understanding of relapse and lapse, and less a punitive approach to that, a more supportive approach to that. More meaningful activity, less time locked up, and recovery environments that are conducive to well-being. Okay.
Oh, wonderful. That was so comprehensive, Matt. I'm not sure anybody else will have anything they could possibly add to that. Anyway, we will keep going. So I'm going to go next to Craig. Craig Reid. Hi, Craig. Are you there?
Hi, yeah, apologies, just coming off mute. So a small group of 3. It's got a couple of points really, mainly focusing on part A really in terms of the building blocks. I'm just having a look at a few notes.
Sure.
Just a minimum standard in terms of training psychosocial workers. In discussion with some colleagues, there's considerable variation between providers there. We need to tap into the lived experience that's already in prisons at the moment, and perhaps include some kind of recovery champion strategy. One provider mentioned that the psychosocial workers have a lead role for recovery champions, but I suspect that's not kind of a uniform thing across the board. In terms of ISFLs, potentially more guidance as to what ISFLs are for, because there's kind of a school of thought that might suggest that at the moment they're really simply enhanced wings. So perhaps that could be more robust criteria for entry and more training for staff that are actually working on those, and potentially more effective drug testing for those wings. In terms of trauma-informed care, we think that unless you're delivering working in a trauma-informed care way, you're not delivering the best care. But how do we do that safely? Because you can open up a can of worms there really with asking people to open up and then returning them to a space where they haven't got space to kind of decompress in a safe way. And how can we achieve that? Because people can get strong emotions when they open up, and then that can lead to anger, which obviously in a prison leads to other issues. So I think they're just a summary of some of the things we came up with.
Thank you, Craig. That's really helpful. And this is really useful. We will take a note of all of these things and we will feed them back to you now. I'm not going in any particular order. So Sheila, are you there, Sheila? And did you have your hand up? I hope you had your hand up for this anyway.
I can't see a Sheila.
Oh,
David, are you looking in the chat in the people section? If you look in the people, yeah.
Yeah, I'll go. I'll try again. Then we'll go with Michelle. Michelle Vosper.
Hello. I was thinking I was going to be at the end then, David. Thanks for jumping me up the queue.
Oh, you must know about my utter randomness.
Oh, I'm liking it. So we were in a group mixed. We had a really interesting colleague on who was in Canada. So we talked about Canadian correctional and drug and alcohol services there. And then some people that were in sort of prison roles in recovery in the UK. We spoke about there are good building blocks. So little things for me like the HMPPS drug and alcohol framework, the subtle shift of going 6 recovery priorities, plug in Mike's hard work with that. But I do think it's allowed us to have a conversation that when I started in role 2.5 years ago in probation, health and justice, kind of recovery and continuity of care was the third agenda, like the last agenda item in most of the meetings I joined, and now we can kind of bump it up with recovery at the top. So we said that was a positive shift that is filtering into the prisons. I think everybody said that there's some really good work. The energy is really good in the different places that we're all working. There's good initial information around kind of the people's needs when they come into prison, and really hard work in the treatment space by the teams. But it was kind of that it's how you sort of exit somebody from a need to be open to treatment in a prison and then into recovery as a general population, I guess, if that's the right language. So we said that was the part B bit, was how do we get recovery all the way through it? I didn't say this in the chat, we ran out of time, but for me, the continuity of care, having a shared goal for the 75% into structured treatment was a massive game changer for us in probation, because we were able to join a conversation that wasn't necessarily our full conversation, but they are our people we supervise. We all worked at that aspiration. So could we now have a tangible target of how many people can we get into recovery, and can we measure that in a way that is tangible so that we all have something to kind of aim at? We talked about having standards, so, and if the standards are there, different people in their roles not being pulled into other parts of the prison. So Jo was talking heavily about, you know, wanting to do good work in the treatment role that her team's in around recovery, but then getting pulled into sort of broader healthcare asks, and, you know, the prison being able to sort of like the sort of daily impact of prison activities, not letting some of the better stuff happen, and how does the system understand what we're all trying to do? So yeah, we had a really good conversation. We couldn't quite solve it or get there, but we had a lovely conversation.
This is the start of the discussion. We're not we're not expecting solutions. We want to work with as many of you as possible to develop and test solutions as we go forward. Natalie, how are you, Natalie?
Yeah, I'm good, thanks, David. So we've answered the questions we thought you'd asked, because none of us got to take a picture of them. So I apologise if some of this might not be quite right, but I'll go for it anyway. There's already been some talk about, for question 1, peer mentors, lived experience and mutual aid, and the real value of that, and how that would be a good building block to move forwards from. We talked about there's good communication systems moving through the gate, although it was recognised that might not be replicated across the country, and that might be in more pockets of certain areas. Partnership working, I think the colleague who last spoke as well talked a little bit about this, not just partnership working, but there's a lot of people who do want to do the right thing as well, and actually having that base level is a good starting point to move forwards from. So moving on to the second part of that question, we talked about perhaps having an understanding of what's already in place, and then kind of having a bit of a gap analysis about what's actually missing, you know, what's actually missing, and what do we need to strive to achieve in terms of these quality standards. Standardising the selection criteria for peer mentors by way of expectations, training, what they're used for as well. Giving people something purposeful to do, having a purpose, so there's a lot less boredom. And we talked about connecting services together to support individuals, and how it would be good to do that. But going back to the point about communications, systems not necessarily being consistently good up and down the country. I think a colleague's already talked about information sharing, which we also had some conversations about, and a recognition that we do need to turn the HMPPS drug strategy into a reality, and move away from having an approach of punishment, and focusing more on recovery as well. So I think that's just about covered everything, David. Thank you.
Brilliant. Thank you very much, Natalie. Katie?
Hello, you all right?
Yeah, how you doing, Katie?
I'm good, thanks. Are you?
Yeah, all good.
We had quite a large group, I'd say. And I think there's a lot of similar answers that have already been mentioned, like the likes of obviously having a lot of lived experience presence within the prison. I think vetting's obviously been spoke about a few times, and that seems to be one of the biggest barriers. But men and women resonate with people who've got lived experience. That's just a given, so that would be great to have that more. There's one initiative that was mentioned about there is a lived experience worker who will work with people who are using maybe sporadically, they don't want to engage with services, so they'll sort of target them a little bit more. There might be like one-off spice usage and stuff like that, and that seemed like a really good initiative. That's working well there so far. There was a lot of joint up working with healthcare more. Obviously, there's massive stigma with healthcare and prisons as well. So if they're mixed with recovery services, I think someone mentioned that earlier on anyway in the chat, that there can be a bit of a stigma sometimes and people can be a bit reluctant to engage with healthcare, and there's a bit of confusion with who's doing what, especially with there being so many different services in different prisons anyway. Resources we'd noted down can be a bit of an issue in terms of there's all this great work that can be done, but there's not enough recovery workers, or there's not enough drug service workers, or so just similar roles to that are not the greatest amount of people can be targeted. I spoke about within my state, so HMP Millsike, there was maybe a little bit of stigma around people who use substances, so we've been engaging with the men a lot more to see how they want to sort of share their story if they're comfortable with, so utilising their lived experience story, because just because someone's in prison it doesn't mean to say they're not in recovery and they haven't done amazing recovery themselves anyway, so we want to be able to share that story and just have that visible recovery across the prison. There was a great initiative through the Hep C Trust where they've trialled a few prisons where the actual men do the testing on the other men as well, so a bit like a trainer, which is just great and just utilises more skills. So there's only 3 sites at present doing that, but I'd imagine because there's a lot of behind the scenes about that, I'd imagine, but that would be an ideal thing. I think a lot of different prisons sharing good practice across everyone, so we'd mentioned systems as well, that there's obviously so many different systems that you got to use. Like me myself, I've got 3 email addresses that it's hard to keep up with, so if we all use one system, that in itself could just help things, because then you can share that good practice even more. But as well, just sharing your knowledge as well, so it wasn't just prison discussions we had, it was community discussions we had as well. So it was about, say, the probation services working with lived experience recovery organisations, not just them helping people on probation, but helping probation as well, because there's a lot of people who maybe don't understand the recovery world. They may just solely go off the medical model, and yeah, that works for some, but obviously it's tailored to that individual, isn't it? You need to know what's available, so it's about just sharing that experience with everyone. And I think the biggest thing that we said that was from that could be implemented is the lived experience recovery organisations being so much more present in the prisons and in the community. Obviously, it's a little bit easier in the community, and just upskilling the staff workforce in the prisons, upskilling prison officers as well, making sure that there's no stigma there, because that can be one of the massive barriers. And it was about overall more staffing. And I feel like I've covered everything outside of what's already been mentioned.
Brilliant. That is fabulous, Katie. Thank you. So, and these are big themes that are coming up: challenge stigma, awareness raising, visibility of lived experience. And I think you've touched on something really important. 3 kinds of lived experience we can think about. Find your own. Who are the people in your prison already who are in recovery? Yeah. Grow your own, develop your own recovery champions, partner up with Leros and bring people in as visible icons of recovery. Wonderful. Yeah. Nicola.
Hello, David.
Hi, Nicola.
So our group was, we had 4 in our group, and again, we spoke about lots of things which have been said about sort of recovery wings, ISFLs, and what happens within the main prisons. So a lot of what's been said we covered as well. One of the things which was brought up, which I've never heard of before, and it was around Chris Carson brought up about the effectiveness of having culture champions. So again, we look to sort of patients for lived experience and peer support, but Chris was saying one of the things which has been really effective within sort of areas where he's worked and he's seen that it's been able to get that momentum of good practice and change going is actually out of your workforce identifying colleagues who can set the tone and basically be those who will maneuver other staff through this process and bring them along the journey. So they may not necessarily be on that pathway first of all, but then by having the right staff in the right places, they can help bring about change, which addresses some of that like culture aspect. You know, that sometimes there can be a particular culture, maybe within a wing or within a prison, which will really maybe prevent a recovery focused wing developing at the pace that it needs to develop, because you've got not a very good culture on there. And then the other thing which Chris mentioned, which hasn't been mentioned as well, if you want a recovery pathway to be success across a prison, is looking at what other pathways you've introduced into the prison. And Chris mentioned about the segregation sort of pathway he'd worked on with Linda, and that there were certain elements of that which had been a real success and had helped to embed that across prisons, and for it to become a pathway which was embraced by the whole workforce and therefore was really successful. And therefore looking at what happened within that pathway that has made it so successful and being able to be embedded into normal practice, because then applying what made that successful to what we're wanting to make successful could help again just get change across what, you know, prisons and what we're trying to achieve. So I think they're the two things which haven't been mentioned so far of what we picked up in our group, as well as the important things around sort of you know, integration of teams, training, reportable activities. Recovery and substance misuse is never on the sort of HMPS as a reportable activity around performance, and therefore, like one of the other colleagues on the call mentioned, quite easily the substance misuse groups get shelved because it's not a reportable activity. So things like that need to be addressed as well.
Brilliant, wonderful.
I think that's everything from our group.
Thank you. I love the idea that we could link education awareness raising to the idea of culture carriers and champions, so that potentially you have multiple culture carriers within any given prison. Sammy?
Hi.
Hello.
So again, we spoke about quite a lot of the same things that other people have mentioned. So the ISFLs, having wings that are a little bit more open, that allow people to take ownership of the wings and running themselves, making sure that services are kind of shaped by those who use it. Again, the importance of lived experience, the impact that that has on staff, involving staff within prisoners' journeys and bringing people back into prisons who have had a successful journey. So it shows staff that they're not just seeing the same revolving doors returning into custody. We talked about additional funding that are available from different funding streams, so maybe it's a little bit more co-commissioning that happens, and making sure that all services are kind of involved in that commissioning element. So if there is additional funding put into healthcare, and for example, if there were community services were having in-reach workers for prisons, but then making sure that the probation service and the prison were involved in the development of those roles, to make sure that everybody's benefiting and that the funding's being used correctly, so that everybody gets the outcomes that are intended from that additional funding. We talked about building on recovery services that are out there, so on LEROs and recovery services, and making sure that we have recording systems that reflect that, so that we can follow people's recovery journeys even if they don't go into structured treatment. So how can we make sure that people can best utilise the support that's out there and use routes that work for the individual, because not everybody will benefit from going into structured treatment, but how do we capture that, and how do we make sure that we can support individuals into all aspects of recovery rather than just focusing on them traditional pathways that we usually see.
Yeah.
And again, around that collective commissioning and making sure that it benefits everybody. I think those are the bits that we picked out that haven't been
Thank you,
spoken about.
thank you. And I really like the idea of that kind of alternative funded mechanism. So it's part of that whole prison initiative. It's across the board there. So thank you. Next, Tracy.
Hi, I was in a group of two, so Daniel, who's got his hands up, he's got the feedback from part A, and I'm going to do part B. So,
fabulous.
Yeah, what we looked at is for part B about the initial steps in building the quality is, I think for the standards to be right and purposeful, there needs to be a review of current contracts, and within those contracts, it's about the recruitment and the retention of staff in our partner agencies, because with all of the things that we would look at to be able to deliver, particularly with the new framework of the enabling recovery for the first 6 objectives, we really do need our partners to be in a position where the resources, the basic resources that were withheld in that contract are available, and if not, what is a plan B to enable us to continue to deliver the standards of that service, that hopefully once we've progressed forward we will be in a really good position, because without the grassroots level staffing available, it doesn't matter how many standards or the thresholds of standards. If we do not have the staffing available from our partner agencies, it is impossible to deliver. There's one other point to that as well, is I think there should be some time spent looking also at weighting to certain parts of the country as well. So those difficult to recruit to, it always ends up, being in London waiting. But why can't we look at those areas that are really difficult to retain and recruit into, and actually put some more funding into those parts of the country as well?
Fabulous. That's a completely different perspective. So we'll stick with your group, and I will go to Daniel for the second question.
Hi, yeah, Dan Billingham from HMPPS. So I'll keep it quite simple, actually, and a lot of this has been covered. So if anything, we'll just add a little bit of gravity to some of what's already been mentioned. So to part A, I think purposeful activity is an absolute must. Not just about recovery, but all kind of forms of assistance, rehabilitation. But I mean, I'll put emphasis on it has to be purposeful. Of plenty of years, 28 plus years working in and around prisons, and prisoners get up to all sorts of mischief if they're unlocked with nothing to do. So lots of purposeful activity, I think, is key. And then secondary would be kind of physical and procedural inhibitors to getting drugs into prisons. Drone blockers being an obvious one, better searching, more consistent searchings in terms of quality, not just in terms of frequency. So stop stuff getting in and keep prisoners busy.
Oh, wonderful. Thank you so much, Dan. Next on our list is Sarah.
Hi, David.
Hi, Sarah. How are you?
I'm good, thank you. I think a lot of what we said similar has already been covered, but Andrew, sorry, I can't remember his surname, talked about, again, having, because obviously it's a mammoth task to try and, train all staff to become trauma informed, but having those key members of staff, recovery officers on the wing, to try and change that culture. I mean, I know that's already been covered. He did also mention about really good harm reduction advice as well on reception and linking in with healthcare to make sure that that was happening, and that was a really important element. We talked about obviously it being a punitive response, to drug use, and thinking about how that could be more, signposting people and trying to encourage them, to look at recovery rather than those adjudications being so punitive. And then just really, I think, how do we then carry that if this builds and, this is successful, how can we carry that into the community? Because that transition period is absolutely crucial, as we all know. And I think it's really difficult for people when they get out then, especially with, we talked about the legislative changes and that churn of people coming in and going back out very quickly, and trying to take a trauma-informed approach when you can't develop those relationships because people are not there for long enough. That's really difficult, building those trusting relationships. And then just linking into what Tracy said about the staff as well, not just the churn of the people coming into prison, but the churn of people working in prison. So if you're giving them real quality training and then they're leaving the service, how do we retain those staff? And I think that was a lot of what we covered.
Thank you, Sarah. Two fabulous points there. One, I think, is so important. It's always about human connection, and all key individuals are relevant. And in an ideal recovery world, everybody grows and benefits. It's not just the prisoner or the prison family. It's a mutual growth thing. The second thing, I love the idea of it's not just recovery as a narrow abstinence-based thing. It's from harm reduction to meet people where they're at and support them in their journey. Scarlett?
Thanks, David. Thank you for the session today. I don't think we've met David, and I think I've met quite a few colleagues on this call. I find this incredibly helpful. So I'm Scarlett. I work in the National Health and Justice team in NHS England, and I lead on substance misuse and mental health. And I think just reflecting back on the point that Dame Carol made at the beginning, that she really, really liked the National Service Specification for Mental Health. And then thinking about this fantastic conversation that we've just had, one of the key elements that we're looking at nationally is reviewing that service specification. And I think you've just given us a whole heap of reasons why we need to do that. So thank you for this session. And Linda is involved in that work to review the spec. I don't want to repeat what people have already shared, and there was only myself and Luke, who I think was from Lindholm Prison up in Doncaster, had a really, really helpful conversation around things that we can build on, which is obviously trying to stop the drugs from coming in and then reducing demand. And what do we think could be some of the brilliant approaches to respond to that? Obviously, what everybody said we agree with, but the bit that struck me was how we deliver our psychosocial interventions. Historically, they're always in those teeny tiny rooms, or they're out on the wing publicly, or they're in a classroom setting. For a lot of our patients in prison, school was probably not a very nice place. They probably never really interacted in, hospital appointments or mental health appointments. So why are we still doing or using that model when prisons do have some really nice community garden spaces? How can we kind of create a better sense of engagement in psychosocial interventions through alternative methods? Similar to like in the community, you might have art therapy, equine therapy. I'm not saying we're going to bring horses into prison, don't worry, but there are gardens that could be used, and there's lots of other opportunities. So it's thinking, how can we work better with the regime, with the prisons, to really think about where and how we deliver our psychosocial interventions.
Yeah, and I think you could add how. I've never understood why this assumption was once a fortnight, 45 minutes across a desk from someone, whether it's prison or community. Anyway, that might be a discussion for us to have on another day. But thank you.
Thank you.
Now, have we run out of hands, or have I forgotten anyone, basically? No. Perfect. Well, we've almost got our timings perfect, Linda. So I'm going to pass from this Linda back to the other Linda to conclude and get some final thoughts and reflections, I think.
Thank you very much, David, and thank you, Scarlett, for those comments as well, and for the connecting and the connection and the alignment. So I'm very conscious that we've been very privileged to have the ear of Dame Carol Black through this, and I hope it's been a valuable session. I know that we're about to lose Dame Carol shortly, but before I make some closing remarks and try my best, because I don't know about you, I'm pleasantly exhausted at the moment, try my best to try and think about how we package some of this. I'd really love to invite Dame Carol back just to receive any reflections that she might have. She opened up the session and set the tone so perfectly, and I wondered, Dame Carol, if you would have any immediate observations or perhaps some further challenge for those of us here today.
Thank you very much, Linda. I think my observation is, you've had throughout the afternoon wonderfully engaged, enthusiastic people who want to make it better. So you have no problem with people willing and wanting to see an improvement. I think what I would, and lots of good things have been mentioned in all that's just been said now. So there are kernels everywhere of people doing good things, maybe variations across the prison estate. But I think if you develop standards, the real question for me is not making these standards sit on a shelf. So it's all very well having standards, but if they don't actually change practice, and if there's no incentive or sticks, or no regulation or whatever, you need a standard is wonderful as long as somebody is going to make sure it's put into practice, and that there is a price if it's not put into practice. So I wouldn't want you to do a lot of work with a lot of really enthusiastic, determined people, and then not have a vehicle through which it can work. Because it would be nice to see across the prison estate that we have some standards below which you are not permitted to fall, and that we can then keep improving, but for everyone. Because as I said at the beginning, I did see good pockets of practice. It was just that they were pockets.
Dame Carol, thank you so much. Well, first of all, thank you for joining us today. It gives me an opportunity, I know, and if you have to dash off, but and thank you for that challenge. And it made me think, as people who know me, you know, I have a great believer in values and principles, and you want values that are lived, not laminated. And I think your real point to us there, and it is a significant challenge, I think, for us to take away and reflect on. And we will definitely, David and I will have that at the top of the list as a guiding arc. But
I'm sorry, Linda. Sorry,
David,
if
yes,
I can just intervene. From my point of view, I think the aim of standards, Dame Carol, is both to raise the bottom and raise the top. One of the key things is to identify innovation and then disseminate that. So there is something about growth about the process, but you're absolutely right. There's also, we have to raise the minimum standard, because it feels to me there's innovation, but there's also massive postcode lottery and huge variation in quality and practice. And so I think we should aspire to do two things, but you're right, it requires a kind of regulatory framework that allows us the time and space and the trust relationships to implement that.
Brilliant. Okay. Thank you very much
indeed. Thank you very much.
Thank you so much. Brilliant. So there's something about the consequences and not wanting to go behind the bar. We are all accountable, aren't we, for excellence? So I said I was pleasantly exhausted, and I am, which is a good happy space. I'm going to say a couple of things just to say. We came today, we have no real mandate to act. What we have is a load of energy and a great amount of ideas. And what you've done through your, sticking with us and all the fantastic commentary, which I've tried to capture, is make us feel that there's a reason and a raison d'etre to keep going with this. So in terms of what we will do next is Dave and I are going to debrief, and then we're going to try and crystallise all of the feedback that we've got here. We are obviously going to make the content available to you, and then we would like to bring together a working group of the representatives of the Coalition of the Willing. We want to start where we began, which is true co-production, and you can't scrimp on that. You have to actually get people together and make a start. So if we reach out to you and we tap you on the virtual or otherwise shoulder, you'll be invited to be part of that Coalition and the Willing. And the list of people that have joined today are our starting point. But once you've got your slide pack and you spread it about, there may be others who want to join, because this isn't an exclusive club. We're very cognizant that those here on the call have given their time, who have accountable responsibilities for, as Carl put forward, leading on things like service specification reviews or drug and alcohol frameworks. We obviously understand that there are things that need to happen. What we want to do is, with this piece of work, is support that and have your support with it. So that's what we're going to do from here, and we'll use this as the working list to gather the coalition of the willing working group that will start the process off for making this a reality. And that's really all I wanted to say before I let people go and thank them. David, was there anything else that you feel I've missed there in terms of your and ours co-leadership of this?
No, I think from our point of view, we had two purposes today, really to tell people where we are and what our thoughts were about a way forward. And secondly, to recruit your thoughts and ideas and to find out, are other people interested in this? Well, I'm pretty sure we've answered that in the affirmative. And we really look forward to working with you. This isn't for Linda and me to do. We will only do that as part of a much wider group where we're genuinely committed to a principle of co-production and moving this forward. But I think we're both incredibly heartened by what's happened today, and we're really looking forward to working with as many of you as can afford the time and mental space to help us. So just a big thank you from me, really.
There's an evaluation form in the chat, colleagues, and if I am able to give you at least 2 minutes of time back, could you use that 2 minutes to fill the form in and express your desire to be an early adopter site? The gift of time comes with consequences, to use Dame, and commitment, to use Dame Carol's tone that she said. And I know I will express on your behalves, colleagues, our thanks and gratitude to Dame Carol for joining today and putting this on her priority list as well, and I'll do that all on your behalves. To all of our speakers, Mike in particular as well, Mike who joined to give us that really in-depth overview of the progress that HMPPS has made on the drug and alcohol framework as well. I want to thank Mike as well as part of this, and for all the facilitators who fed back so succinctly. Have a great rest of day, everybody, and look out for the information and the content which we'll share with you all. Thank you so much, colleagues. Thank you.
Thank you.
Thank you.
Bye.